Welcome, everyone. I'm Pamela Metz. I'm the Director of Chapter Development here at the Scholar Strategy Network, where I work with our 36 state and local chapters across the United States. It's always a pleasure to see so many familiar faces in these events. I'm joined today by my colleagues Mandana Masanzadigan and Anna Orlin from our membership team, who will drop our links in the chat where you can learn more about the Scholar Strategy Network. Today, I'm delighted to welcome you to the second dialogue in the Georgia chapter's new four-part series on defending U.S. democracy. Georgia SSN is led by political scientists Michael Evans of Georgia State University and Bernard Thomas of Valdosta State University. Now I'm going to pass the mic to Mike Evans, who will say a bit more about the series. Mike will then turn it over to Richard Donor of Emory University, who our moderator for today, to introduce the speakers and get underway.
All right, thanks, Pam, and hello, everyone. Welcome. Thank you for coming. I just want to tell you a little bit about the series that Bernie and I were running through SSN Georgia. We felt that this kind of process we're going through right now of apparent democratic backsliding, autocratization, is something that we all need to. It's a multifaceted problem, nationwide in scope, and so we thought this would be a perfect thing for SSN to do nationally, to invite other chapters from around the country to kind of bring our collective, all of our various areas of expertise to bear on it. Start a discussion with scholars and policymakers, and so that we can understand it better and also understand what can be done. The first session was run by my colleague Jennifer McCoy, who's here today, and she framed kind of the whole series really nicely by giving us an overview, drawing on her expertise from a comparative perspective on polarization and democratic backsliding around the world to help us kind of understand what we're going through in the United States. And she framed it nicely as being about, why is it so hard to build a mass movement to defend democracy? And one of the things that came away from that discussion was a major obstacle is what she calls, regime uncertainty, which is people understanding, exactly what's going on. Are we really going through the process of autocratization? Not quite believing what we're seeing, not quite being able to understand, knowing for sure, what's happening. And this is an epistemic problem. And under ideal conditions, we political scientists, and especially experts like Dr. McCoy, would be in a great position to be able to sound the alarm and inform the public, and that would probably make it much easier to build a mass movement. But of course, we're living in a situation of deep distrust and expertise. Higher education is going through a crisis of low confidence, low trust. All of our epistemic institutions are going through that, and so I didn't realize it at the time when we planned this second session that just how important this would, and how fitting it is for this to be the second event to really focus on this problem of how it is that we can get expert knowledge to be trusted, but also to make sure that our epistemic institutions are worthy of trust, that they are performing at the level that we need them to. And we're going to do this by focusing on through the lens of public health, but we're hoping to draw lessons more broadly that will be helpful for this. And then we have two sessions planned for the spring. Tentatively, one will definitely feature Bernie Tomas, who's an expert on third parties, and we're going to talk about the prospects for third party or multi-party democracy as a possible resolution for our approach to our polarization and backsliding. And then we're going to the fourth one will be taking advantage of the fact that next year's the 250th anniversary of the Declaration. We're going to have a discussion about the prospects for national unity around the old idea of an American creed, that a broad kind of unifying philosophy that could possibly be a solution for polarization. So that's the plan. Hope you all can attend in the spring as well. But I'm going to pass it over to Rick, who's going to get this session started.
Thank you, Mike. Thanks, everybody, for coming. It's really great to have everybody here. And the panel, I think, is especially important for reasons that Mike mentioned, and also for other reasons. The book is extremely timely. As Daniel and others will attest, there has not really been a thorough evaluation of responses to the COVID pandemic, in fact. In addition, the book that will form part of the key part of the discussion is controversial. Obviously, it highlights the challenges of effectively, in terms for scholars, of effectively using our analytical skills to inform public policy. And that's one of the goals of Scholar Strategy Network. The focus of the book, as Francis will discuss, is on liberal democracy, or liberal democracy is key to part of it. And I want to remind folks of the words of Francis's co-author, Stephen Macedo, who said, "The major focus of the book is that the pandemic revealed and contributed to the degraded state of liberal democracy, especially the truth-seeking departments of liberal democracy, science, and journalism." So hopefully this discussion will help us to be forward-thinking regarding the interaction between a science-based public policy on the one hand and our flawed liberal democracy on the other. And most critically, how do we move forward in terms of learning from an analysis of the past? And to that end, we're really fortunate to have two significant participants in this whole process. One, obviously, is Francis Lee, the co-author of the recent book, In COVID's Wake, and How Politics Failed Us. Francis is a professor of politics and public affairs at Princeton, and really is one of the country's preeminent scholars of American national politics, Congress, and policymaking. In addition to the COVID book, she's the author of a number of award-winning books, including Insecure Majorities, Congress and the Perpetual Challenge, Beyond Ideology, Politics, Principles, and Partisanship in the U.S. Senate, and others. She's had a lot of awards, including the American Political Science Association Award for the Best Book on American National Policy, the Fenno Prize for the Best Book in Legislative Studies. She is an associate editor of the American Journal of Political Science, and has worked on Capitol Hill as an APSA fellow, and was elected a fellow of the American Academy of Arts and Sciences. Also with us is Daniel Pollock, who is board certified in internal medicine and emergency medicine. Daniel worked as an emergency physician in the Emory University's Department of Emergency Medicine at Grady Hospital from '86 to 2007. During that time, he also worked at CDC. He completed the CDC's kind of preeminent elite training program, the Epidemiological Intelligence Service. And he worked in CDC as a medical epidemiologist in the agency for 35 years. He led the CDC unit responsible for national surveillance of healthcare-associated infections from 2004 to 2021, and he served in the CDC's COVID-19 Emergency Response Unit in the spring of 2020 as Deputy Incident Manager for Data and Surveillance. He retired as a branch chief in CDC's Division of Healthcare Quality Promotion. In addition, or rather in reflecting on his work in public health, Daniel has written articles on the institutional and political features of COVID and our response. And one is a piece entitled CDC in the Pandemic's Wake, an article that emphasizes the need to address what Daniel calls institutional ignorance in the CDC. He also has written another article published in the Journal of Medical Humanities that challenges the individualized and racialized lenses through which much of the media covered the CDC outbreak. Unfortunately, our colleague Mike St. Louis, also of the CDC, could not make it for health reasons. So I'm Rick Donor. I am an emeritus professor of political science at Emory and now teaching in the Rollins School of Public Health. So we are going to proceed as follows. we're going to ask Frances to lead off with 15 minutes summarizing key points. She has some slides. Then Daniel, 15 minutes. I will ask the two panelists a question, and they'll have roughly 10 minutes to respond. And then we open it up to the audience for Q&A. So please use the raise your hand function, and I will call on you. So with that, I will turn it over to Frances. Thanks very much for being with us.
Thank you very much, Rick. Thanks for that introduction. And thanks also to Mike and Bernie for organizing this session, and also to Daniel for participating. Let me get my slides. I'm going to run through an overview of the book in the time that I have. That will set things up, I hope, for a meaty discussion, given that I wouldn't assume that many people would have had a chance to engage with it yet. My book with Steve Macedo is a story of elite failure. We focus on the performance of the major truth-seeking institutions of liberal democracy, namely science agencies, journalism, and universities. All of these institutions have suffered losses of public trust in the wake of the pandemic. We argue that this loss of trust is not entirely unreasonable or unwarranted. We are, of course, sensitive to the extreme nature of the crisis. If you think back to March and April 2020, the fear of that time was overwhelming. Hospital wards in northern Italy were overwhelmed. Nobody knew just how bad it could get. New York City was also hit hard, as we all remember. We recognize that decisions were made in conditions of fear and uncertainty, and one can only feel empathy for public officials who are tasked with leadership during such a time. It was the greatest global crisis since World War II. By early April 2020, half of the world's population, 3.9 billion people, was under some form of lockdown. It was the worst pandemic since the Great Flu of 1918-1919. So, of course, mistakes were made. Nevertheless, we need a comprehensive assessment. Steve and I began by going back and looking at what we knew or thought we knew about pandemic planning before COVID. There are numerous pre-COVID planning documents that speak to these questions. Just months before the pandemic struck, the World Health Organization published in November 2019 a systematic review comprehensively assessing the various measures that were proposed as potential tools for pandemic management. The report emphasizes uncertainty, rating the evidence in favor of all these measures as low or very low. On page 3, there's a summary table listing measures that are not recommended in any circumstances for a respiratory pandemic. Among those are contact tracing, quarantine of exposed individuals, entry and exit screening, and border closure. All measures that would be deployed all around the world in response to the COVID pandemic starting in March 2020. The document discusses school closures as potentially helpful during a respiratory pandemic, but it also notes that they raise major ethical issues for families and communities. Another planning report put out in September 2019 by the Johns Hopkins Center for Health Security also underscored that it is uncertain whether restrictions would be effective at preventing or limiting transmission in society. The report reads, it's important to communicate to political leaders the absence of evidence surrounding many non-pharmaceutical interventions and the adverse consequences that may follow them. Given the skepticism, when and how did ideas for widespread use of non-pharmaceutical interventions get so much support? These ideas gained a lot of currency during the presidency of George W. Bush. During his summer vacation in 2005, Bush had read a book about the 1918 pandemic, John Barry's Great Influenza. He gave a major address and tasked his Homeland Security team to work on pandemic preparedness. This group, in turn, was heavily influenced by the work of a set of mathematical modelers in academia and at Sandia National Laboratory. They developed a strategy document, the National Strategy for Pandemic Influenza. They were especially enthusiastic about the potential for school closures in reducing disease transmission. The strongest evidence in favor of social distancing measures rested on an influential study reporting that cities that had imposed non-pharmaceutical interventions during the 1918 pandemic, meaning closures of schools, churches, and theaters, had suffered 50% lower peak death rates. On the basis of this research, U.S. pandemic planners began to call for non-pharmaceutical interventions in the event of a pandemic. But this containment strategy that Bush's Homeland Security advisors advocated remained controversial at the Centers for Disease Control and other health agencies. If you've ever read the book, The Premonition by Michael Lewis, it documents some of the controversy around these ideas. To adjudicate the controversy, the U.S. Department of Health and Human Services issued a grant to the Institute of Medicine, which has since been reconstituted as the National Academy of Medicine, in order to review the evidence. The Institute of Medicine assembled a distinguished group of public health scholars, epidemiologists, and biostatisticians. In the report they produced, they declared themselves unconvinced. They emphasized that mortality in the 1918 pandemic was only weakly associated with the interventions, and that the model does not explain much variation across cities. The report declined to endorse the new pandemic strategy because it is almost impossible to say, as they wrote, it's almost impossible to say that the interventions, either individually or in combination, will be effective. Among the skeptics of the value of non-pharmaceutical interventions was Dr. D.A. Henderson. He was one of the most famous and decorated epidemiologists in the U.S., who had led a 10-year successful global effort to eradicate smallpox. He also served as the dean of the Johns Hopkins School of Public Health for 13 years. He co-authored a paper critiquing the Bush-era pandemic plans and questioning the use of non-pharmaceutical interventions for controlling the spread of respiratory disease. The paper raises critical points about pretty much all of the ideas in the Bush planning document and concludes with a blanket recommendation against the use of quarantine during a pandemic. As experience shows, there is no basis for recommending quarantine, either of groups or individuals. The problems of implementing such measures are formidable, and secondary effects, such as loss of public trust in government, are likely to be considerable. So much for the pre-COVID pandemic planning. When the pandemic broke out, U.S. policy turned on a dime. The first domino to fall was the Wuhan lockdown, imposed on January 22nd, which was the largest quarantine in human history to that point, covering 60 million people. That reaction, the reaction in the U.S. to the Wuhan lockdown was skepticism. As Dr. Anthony Fauci told CNN, he said, that's something I don't think we could possibly do in the United States. I can't imagine shutting down New York or Los Angeles. But the judgment on the part of the Chinese health authorities is that this is something that, in fact, is going to help in containing it. Whether or not it does or does not is really open to question, because historically, when you shut things down, it doesn't have a major effect. The next shoe to drop was on March the 16th, a bombshell report issued from a team at Imperial College London led by Dr. Neil M. Ferguson. Ferguson was a longtime advocate of non-pharmaceutical interventions who had co-authored papers with some of the Bush-era pandemic planners. Imperial College's report number 9 made headlines everywhere, predicting over 510,000 deaths in the United Kingdom and 2.2 million in the United States by August of 2020. The model projected, however, that the implementation of non-pharmaceutical interventions would significantly cut that horrific death toll. Now, we all remember the many press conferences during the pandemic with President Trump and Anthony Fauci and Deborah Birx and others. But the key policymakers during the pandemic were the nation's governors. During the crisis, it was the governors who decided on closures and when to lift them. And amid the crisis and uncertainty, they looked to federal officials for guidance. No clear guidance emerged until March the 16th, when the president convened a major press conference with health officials. This is the announcement of the 15 days to slow the spread. At that press conference, the administration issued recommendations that in states with evidence of community transmission, governors should close non-essential businesses, and all places where people congregate, including schools. The lockdowns began to cascade across the states afterwards. Nearly all the governors issued stay-at-home orders in the aftermath of that March the 16th press conference. At that point, there were only slight partisan differences. Compared to Democratic governors, Republican governors took just a few more days to issue those orders. But the variation in the lifting of the orders was much greater. Democratic governors kept their orders in place 2.5 times as long as Republican governors did. By March the 25th, all public schools in the United States, serving more than 50 million students, were closed. Across the South and the Mountain West, schools reopened in August of 2020, but nearly half of public schools were still closed in March of 2021. The length of school closures strongly correlates with states' partisan lean as gauged by the 2020 presidential vote. The more Democratic the state, the longer the school closures. At the same time as governors implemented stay-at-home orders in March of 2020, they also imposed other orders to enforce social distancing. To track these patterns, researchers at Oxford University compiled a stringency index to measure the restrictiveness of the pandemic response based on the indicators shown here. The index is scaled from 0 to 100, with 100 being the strictest. This figure displays the average stringency index score for each month of the pandemic for states grouped by their vote for president in 2020, from strongly Republican states shown in dark red to strongly Democratic states shown in dark blue. The most important thing to know from this figure is that the states stay well sorted by party in the stringency of their COVID restrictions, with Democratic states always more stringent than Republican states throughout the crisis, and party-competitive states generally fall in the middle range. And this is true no matter what's happening in the pandemic, as waves would come and go from place to place. Okay, so we can see that there is a big COVID policy divide based on political party. What were the results? Every state carried out a mass vaccination campaign paid for by federal dollars. But there was markedly higher acceptance of vaccines in Democratic-leaning states than in Republican-leaning states. It's a pretty strong, straightforward linear relationship with an R-squared of 0.76 between the share of residents getting fully vaccinated and the presidential vote in the state in 2020. This figure displays cumulative COVID mortality per capita for each month of the pandemic in states grouped by partisan lean. If you look on the right-hand side of the graph, you see that by January 2023, Republican-leaning states had suffered mortality rates nearly 30% higher than Democratic states. However, if you examine COVID mortality across the period before vaccines became available, there is no meaningful difference. The differences in COVID outcomes across Republican and Democratic states first emerge and then grow progressively wider over the period after vaccines were available. The analysis points to a strong relationship between states' level of vaccine uptake and their COVID mortality rate. The least vaccinated state experienced fully 1.6 times as much COVID mortality as the most vaccinated state. However, the different policies states pursued before the vaccines were available do not correlate with COVID mortality. States that imposed stay-at-home orders more quickly did not fare better. Keeping stay-at-home orders in place longer does not correlate with better outcomes. States that kept schools closed longer did not fare better in COVID outcomes than states that reopened them more quickly. Finally, states imposing more stringent COVID restrictions did not fare better than those with less stringent COVID restrictions. Now, what about the cost side of the ledger with respect to these policies? There's not time to go through the research in all these areas, but I will hit a few points. The response to the COVID pandemic entailed the most extensive and lengthy disruption to education in history. The National Assessment of Educational Progress showed unprecedented drops in student learning in reading and math. And there has not been any large-scale recovery since. That poor recovery likely results from chronic absenteeism Rates of chronic absence have doubled relative to before the pandemic. Learning losses were greater in high poverty districts, for Black and Hispanic students, and for students who were struggling academically before the pandemic. The COVID pandemic triggered the largest ever crisis response in United States history. Congress authorized more than $5 trillion in new spending, most of which was allocated to keeping businesses and workers afloat through the closures. Gauged by new spending relative to gross domestic product, 2020 pandemic aid was bigger than the 2009 stimulus package and the whole New Deal combined. 2021 pandemic aid was roughly the same size as the New Deal as a share of GDP. All of these expenditures were added to the national debt. As you can see here, the pandemic response caused an unprecedented rise in the debt to GDP ratio, and this higher debt burden will make responding to the next crisis or recession more difficult. Pandemic policy affected population health, in addition to the effects of the pandemic alone. There were lengthy delays imposed on non-essential or elective care, followed by significant backlogs once that care resumed. Cancer screening declined drastically. Excess deaths during the pandemic were surprisingly high, even in demographics little affected by COVID directly. There were surges in deaths due to heart disease, diabetes, overdose, and homicide. Minority populations were especially adversely affected. More than a third of excess deaths among Black Americans were not explained by COVID. Effects on mental health were also well documented, with increases in anxiety, depression, and eating disorders, particularly among children and adolescents. There was also a sharp increase in substance abuse and overdose during the pandemic. So what have we learned? And here is the epidemic crisis that I see as stemming from the pandemic. During the pandemic, it was claimed that that policy should follow the science, as if the science was settled, when instead there was a lot of controversy around how to handle a pandemic in the scientific literature before COVID. But in the wake of the pandemic, we find questions about science and policy even more settled than they ever were. We haven't learned much in scientific terms, or that's the assessment of the Scottish government's independent but government-authorized COVID inquiry, which was published in July 2023. With respect to non-pharmaceutical interventions, the report concluded, in 2020, there was scientific evidence to support the use of some of the physical measures adopted against COVID-19, as in frequent hand washing and the use of PPE in hospital settings. But for other measures, namely face mask mandates outside of hospital settings, lockdowns, social distancing, test, trace, and isolate measures, there was either insufficient evidence or alternatively no evidence, and the evidence base has not changed materially in the intervening 3 years. The situation is similarly ambiguous on the political front. Democratic and Republican governors all claim credit for handling the pandemic well, and governors all across the United States remain highly popular through and after the pandemic, the vast majority of whom had approval ratings above 60%, and they were largely vindicated by the voters. In addition to Newsom and DeSantis, governors associated with every position on pandemic policy resoundingly won re-election in 2022. There's been no convergence of public opinion about what worked or not. Instead, American public opinion about pandemic policy grew progressively more party polarized across the pandemic. Democrats continued to view public health officials positively, while Republican assessments declined markedly. So that's where things stand at present in this unsettled state. And so I think it's especially appropriate to be able to talk about this book in the context of a panel on the epistemic crisis.
Thanks so much, Francis. Now I'm turning it over to Daniel.
Thank you, Rick, and thank you, Francis. Hello, everyone. I really am grateful to be with all of you and have a chance to talk about this very important topic that we're covering, or set of topics. At the beginning, I'll just say kudos to Francis and Stephen for spurring us to take stock of the policymaking process, policy choices that were made, and the implications of those decisions in COVID. Politics in the United States failed egregiously in efforts to address COVID-19 pandemic policy questions promptly, effectively, and fairly at all levels, local, state, tribal, and national. Much has been written and discussed about the entwined health, political, social, and economic crises that beset America and the world beginning in early 2020. Those mounting troubles called for prompt, effective, and equitable interventions, but an epistemic crisis, complicated in important ways, crippled the response to COVID-19 in the United States. We're still sorting all of that out, what went wrong and why. I think many of us, if we're working, and I guess I'm retired, but also working, could spend quite a few years ahead trying to help sort out what's happened. But one lesson is clear: a barrage of misleading or false information, including pronouncements by some scientific experts, journalists, public health professionals, and others, eroded trust in public health institutions and hindered countermeasure decision-making, deployment, and effectiveness. Hopefully, we can learn from that experience. In keeping with Stephen and Lee's and Francis's analysis, I agree that mismanagement of the COVID crisis was closely tied to political failures to engage a diversity of knowledge and perspectives beyond the biomedical. Instead, policymakers sidelined relevant forms of expertise, a process that interdisciplinary scholar Maru Mormina describes as epistemic narrowing, and that she characterizes as an epistemic injustice. Mormina's look back at knowledge, expertise, and science advice during the pandemic, published 3 years ago in the journal Social Epistemology, follows philosopher Miranda Fricker's theorizing. For Fricker, the primary form of epistemic injustice is denying credibility to individuals who, because of their social identity and marginalization, don't receive the epistemic authority they deserve as givers of knowledge. Think, for example, of experts deemed outside the public health mainstream, whose concerns early in the pandemic about use of non-pharmaceutical interventions, I'll use the term NPIs, also known as community mitigation measures, were disregarded and in some instances disparaged as fringe or dangerous beliefs by leaders of public health institutions. On that score and several other instances of epistemic injustice, I agree completely with Stephen and Francis. Sadly, there's lots to look back on and call out. Shame on the director of the National Institute of Health and the director of the National Institute for Allergy and Infectious Diseases for their response to the Great Barrington Declaration. They abused their epistemic authority, and their behavior was simply reprehensible, regardless of the merits of the declaration, which are contestable and, in my view, warrant contestation, perhaps not this afternoon. I also agree with Stephen and Francis that the dearth of reflection about what went off the rails in COVID-19 is itself a sign that something is still wrong. And I'll just add here that within CDC in 2022, then Director Walensky commissioned an internal review of what went wrong, lessons learned, and announced in August that CDC had made very many public mistakes in the area of communications, testing, and data. However, that full report has never been issued. That's an example, again, of a lack of forthcomingness and transparency, even in the aftermath of the pandemic. The sooner lessons are learned and applied, the better, which is a widely shared viewpoint that animates in COVID's wake how our politics failed us. However, that said, any efforts to better understand failure also can fall short on epistemic grounds if evidence, analysis, or interpretation are faulty. Bearing that concern in mind, I want to discuss 3 propositions that are foundational to In COVID's Wake, yet weakly supported. First, the proposition that experts who influenced COVID-19 policymaking in the United States disregarded a pre-pandemic orthodoxy that non-pharmaceutical interventions, NPIs, would be of limited usefulness in thwarting a viral respiratory disease pandemic. Second, the proposition that early in the pandemic, an elite consensus took shape in the United States that embraced China's draconian COVID-19 response and ignored earlier concerns about the Chinese approach. Third, the proposition that early in the pandemic, there was little difference between COVID-19 mortality between states that adopted more stringent NPIs and those that did not, which is to say, mortality outcomes in red and blue states were similar. The first proposition banks largely on a reading of several domestic and international plans, guidance documents, and commentaries that Francis has reviewed and that were published from 2005 through 2019 in anticipation of a future influenza pandemic. Yet textual analysis does not substantiate the notion that influential experts agreed before COVID-19 emerged that NPIs would have little or no value in thwarting a rapidly spreading, highly virulent respiratory pathogen. A prime example is the Federal Influenza Pandemic Preparedness Plan, more specifically, the 2017 update, which was published closest in time to the onset of the COVID-19 pandemic and is cited in COVID's wake, but receives far less attention than the earlier 2005 and 2006 versions of that plan. The 2017 update does not square with the claim of a uniformly skeptical attitude among experts toward non-pharmaceuticals. Community mitigation measures, according to the 2017 plan, are the first line of defense against pandemic influenza and may help reduce the spread of other respiratory infectious diseases. They can be used from the earliest stages of an influenza pandemic, including the initial months when the most effective countermeasure, a vaccine against the new pandemic virus, might not yet be broadly available. The second weakly supported proposition is that many experts in the United States created hastily cobbled together untested pandemic plans in March and April 2020 that embraced China's COVID-19 response model. According to COVID's wake, the new plans incorporated previously disfavored approaches, such as large-scale quarantine, border closures, contact tracing, and other NPIs. Yet China's domestic controls had no parallel in the world, and nothing close to the Chinese COVID-19 model was deployed in the United States. As Edward Alden, a senior fellow at the Council of Foreign Relations, and Lori Troutman at Western Washington University put it in their book titled When the World Closed Its Doors, published last January, quote, small outbreaks of the virus in China triggered savage lockdowns in which millions of people were confined to their apartments, tested daily, and hauled away to government quarantine facilities in the event of a positive test. To be clear, nothing like that happened in the United States. The third proposition, that there is no relationship between the stringency of a state's non-pharmaceutical interventions and COVID-19 mortality, rests principally on a study that Francis summarized, reported in COVID's wake, of cumulative COVID-19 deaths per resident population in Republican and Democratic states, which were categorized along party lines according to 2020 election results. The finding that Democratic states surpassed cumulative mortality in Republican states each month from March 2020 through November 2020, as shown in the graphical depiction that Francis displayed, seems to be at odds with a second finding reported in the accompanying text that there was no statistical difference between the cumulative death counts in Democratic and Republican states aggregated over 10 months. How can you have monthly totals that were higher consistently in Democratic states, but then have no statistical difference in the totals aggregated over the 10 months, March 2020 through December 2020? However, despite these seemingly discrepant findings, the conclusion is drawn that there was no meaningful mortality difference between Republican and Democratic states, suggesting that their policy differences had no bearing on COVID-19 death rates. Maybe I'm missing something. The method's description is sparse. State-level data are not provided in a tabular, reusable form, and visually differentiating the various lines in the graphical display in the book, much better with the color coding today, is challenging. But I found the analysis, findings, and interpretation wanting. Perhaps more than my critique of what was done is the question of why the authors did not use readily available mortality data to compare excess deaths in two groups of states, Republican and Democratic, or at least mention excess mortality studies that have been reported, such as University of Virginia economist Christopher Room's research published in July of 2024, which suggests that stringent COVID-19 restrictions as a group were associated with substantial decreases in pandemic mortality. There are many studies that have been done and many more to come about the effectiveness of what was implemented. I would say there is no consensus at this point about effectiveness or lack thereof. My concerns about foundational propositions are heightened by a key takeaway message in COVID's wake. The first lesson to be learned from COVID, Stephen and Francis conclude, is that carefully considered plans may be discarded in a flash when fears of an existential threat loom. Yet the opposite conclusion also can be drawn from the available evidence regarding pre-pandemic guidance and its use. The operative 2017 version of the federal pandemic influenza plan makes clear that community mitigation measures are the first line of defense, and there's abundant evidence that that guidance was embraced and widely deployed by states early in 2020 as COVID-19 spread throughout the country and cases, hospitalizations, and deaths surged. You can call it panic, but decision-making under conditions of radical uncertainty may be a more useful description of the early COVID-19 response. As British economists John Kay and Mervyn King explain, radical uncertainty arises when we know something, but not enough to enable us to act with confidence. The occurrence of a global pandemic in 2020 was not a very likely event, they observe, even though we knew it was likely to occur at some point. We could only guess what form it would take, and that guesswork was likely to be influenced by past experience with more familiar pandemic pathogens, such as influenza. Carefully considered plans developed with influenza at top of mind were imperfect guides to contending with SARS-CoV-2. Tragically, the call to, quote, reduce social contacts between people in schools, embedded without operational elaboration in the 2017 federal pandemic influenza plan, was rapidly transformed in 2020 to a state-by-state policy to close all schools, beginning on March 12th, when Republican Governor Mike DeWine of Ohio announced the first statewide closure. In a matter of weeks, all states had similarly, or virtually all states had similarly ordered such closures. In retrospect, school closures should have been a last resort rather than an opening gambit, and those shutdowns typically went on far too long without sufficient reckoning and with respect to adverse impacts. Notably, 9 days before Governor DeWine's announcement, Ann Schuchat, CDC's principal deputy director, testified at a Senate committee hearing that, quote, you have this balance between the earlier you act, the more impact it can have in slowing the spread, and the enormous disruption we see with school closures. That's a message that should have been communicated far more frequently and urgently. The upshot of a faulty policy decision and major communication gaps was a profound downturn in the general public's confidence in expert advice. The challenge ahead to restore trust is an enormous project in which lessons learned from the COVID-19 pandemic should spur and guide us. I'll conclude by saying that despite my concerns, I agree with Stephen and Francis on the need to confront many failures during the COVID-19 pandemic. Censorship and social shaming suppressed policy debates. Journalists rarely pressed skeptical questions. This is one of my findings in this study I did of the press coverage of the outbreak in Albany, Georgia, early in the pandemic that implicated a so-called patient zero and unlikely was attributable to that individual. Journalists rarely press those skeptical questions, and universities likewise limited discussion. Policies that were pursued lacked measurable goals and timely follow-up evaluations that took costs into account along with putative benefits. And policymakers and journalists treated biomedical experts as the only legitimate authority on pandemic policy. I also concur with Stephen and Francis's conclusion that engaging in thoughtful deliberation and respectful debate, especially when there are differing viewpoints, is an epistemic ideal that deserves our utmost attention. My comments this afternoon, including my criticisms, are intended to follow that sage, or should I say, expert advice. I'm grateful for the opportunity to join Francis and you in our program. I look forward to the remainder of our conversation.
Thank you very much, Daniel. So I want to turn it back to Francis for, say, 5 to 10 minutes response to Daniel's points, and then to Daniel. And I wanted to raise a particular question to the extent that Francis and you guys want to address it, and that is, how do you think that science or public health agencies, for example, in this case, can best operate with in the presence of scientific uncertainty, maintaining legitimacy and still acknowledging the uncertainty that that many did feel? And to expand a little bit more, how can we do better on this as it relates, as the question of the legitimacy of science and scientific institution relates to the challenges of strengthening liberal democracy? So Francis, you can either respond directly to some of Daniel's concerns or to the questions that I raised. And I'm going to give you 10 minutes and then stop you.
Okay, sounds good. I appreciate very much Daniel's close and sympathetic reading of the book. I'm grateful also for him drawing out some of the themes that I neglected to cover in my overview. The book is not just about response to the pandemic. My presentation, I focused on the policy history and the effects. But there's more to reflect on, which was the state of the debate and the range of voices that were heard during the process, and the ways in which some voices were excluded. And so all of those are very important points that I hope that we'll be able to grapple with, and I appreciate Daniel drawing those out. I'll focus on the 3 points that Daniel raised in criticism of the book. So first, on the question of the whether there was an orthodoxy opposed to non-pharmaceutical interventions in advance of the COVID pandemic. The way Steve and I read the literature was that there was a group of pandemic planners, mostly drawn from mathematical modeling approaches to pandemic planning, who were very influential beginning in the George W. Bush years, who advocated for these approaches and who produced analyses of the 1918 pandemic, suggesting that they would work. Mm-hmm. That pandemic plan that those Homeland Security Council advisors produced became the basis of that 2017 update that you referenced. There's not a lot of difference between it, except to say that the 2017 document is more elaborate. But it still rests on that same research and was driven by those same advisors who just barreled through, despite the fact that there was a National Academy of Medicine review of their plan, and calling into question everything about it. Despite the fact that there were prominent voices in the field, including Dr. D.A. Henderson, questioning this approach. And then you see the pandemic plans developed subsequent to their work, like in the UK and in states in the US that reject the use of non-pharmaceutical interventions as impractical and unlikely to make a difference. And then you have the 2019 World Health Organization review of the evidence that doesn't offer a full-throated enforcement. Far from it. It points to the weak evidence base behind those measures. So I see U.S. policymakers as just sort of pressing forward with a poorly evidenced policy document. So that's my read on that history. On the question of whether we, in the early going in the pandemic, developed an elite consensus around following the Chinese approach, and cobbled together plans hastily in reaction to it. I would say I certainly agree with Daniel that no other country pursued a policy as draconian as what was feasible in China with their with their health pass. You couldn't enter any public spaces without, passing various checks. It was very highly regulated. People were welded into their apartment buildings. I mean, it was truly extreme, beyond anything we saw anywhere else. But I think what we tried to do in the U.S. was to do as much along those lines as we could. Stay-at-home orders affecting whole states, that none of that was contemplated in the prior pandemic planning. So I think we were influenced by it within the constraints of what we were able to do. On the point about little difference between red and blue states before the vaccine rollout, but quite substantial difference after the vaccine rollout. Our study is not the only one to come to null findings on this. I'll bring up another graph that shows the key findings from another study that on the same question. So this is a study by Thomas Pollock and colleagues, mostly drawn from the University of Washington's Institute for Health Metrics and Evaluation, IHME. The dependent variable here is a little closer to what Daniel recommended, excess deaths. It's not excess deaths, however, it is the dependent variable is age standardized COVID death rates is their dependent variable. The period covers from January 1st, 2020 through July 31st, 2022. And they report, as you can see here, null findings for the use of various closures, bar closures, restaurant closures, school closures, gym or pool closures, mask mandates, stay-at-home orders. All of those produce results that you can't confidently conclude are different from zero on COVID mortality. The only effects that they find that were positive were vaccine mandates for school employees and vaccine mandates for state employees. So that's another study. This came out in the Lancet before our book was published, but after we had already done our first analysis. Our analysis was based on CDC data. It's just COVID mortality by state is our dependent variable. We thought we wanted to be as transparent and simple as possible, and I'm happy for you to review the data directly if you would like to. We wanted it to be as easily and visually inspectable as possible, which is we were frustrated that we couldn't get a color graph in the Princeton University Press book. We requested it. We offered to pay for it. They wouldn't do it. So it's not as good as what I'm able to show you in the slide presentation. There's another possibility.
Francis, I want to make sure that Daniel has a response and that we do Q&A. So why don't you close it with this, okay?
Okay, just one more cross-validating study I want to show you. This is this compares the 29 countries across Europe, and it's a study of excess mortality. And as you can see in the top left corner, there's a clear relationship between the share of people fully vaccinated and excess mortality by country across the pandemic. Clear negative relationship, fewer deaths from more highly vaccinated. They use the Oxford Stringency Index, which is the same indicator we use, shown for 2020, 2021, and 2022 in those three other scatter plots. And you can see they can't reject the null of no effect for stringency of COVID restrictions on outcomes in Europe. It's the same finding that we found when we looked across the states. And I think it's telling because in Europe, the range of variation in COVID policy was even wider than we had in the U.S. Across the states in the U.S. In Europe, you had Sweden, which famously didn't lock down at all. You had Switzerland that locked down only once, and you had countries that had multiple lengthy lockdowns, sometimes even lockdowns after vaccination, and yet they don't find an effect for COVID restrictions, but they do find it for vaccination. So I do think we need a very careful look as to, you know, whether you can ascertain the effect of those measures on the outcome that we cared about the most, which was COVID mortality.
Thank you very much, Francis. Daniel, I'm going to take no more than 10 minutes to, you can respond. I would like to make sure that we don't get too much lost in the methods, unless you want to go into it a little bit more into the data, deal with some of the big questions, including the point that you ended up with, and that is decision-making under uncertainty and crisis conditions.
Right, right. So just, I agree. I mean, we can talk a lot about methods, and I'd love to do so. But I think there are bigger fish to fry here. And you raised a question earlier, Rick, of how science and public health agencies can best operate under conditions of uncertainty. And I think a lot of that has to do with the type of data that are available prior to the pandemic and the type of data systems that are available and operational prior to the pandemic or a pandemic that can be brought to bear. There were enormous gaps in the data that were available. Much of it led to ignorance regarding the differential impact between advantaged and disadvantaged population groups. And that's a takeaway that simply has to be addressed. And I think it's only being addressed in slow motion right now. There's a need to have not only state and county level data, but sub-county level data, because very often there's considerable variation below the county level in terms of the vulnerability of populations within counties. And the CDC has a social vulnerability index that's available only at the county level. NYU has developed a index that incorporates sub-county data. That needs to be thoroughly supported and institutionalized and readily available. So in the event of another pandemic, there can be an early recognition of where the communities that are most likely going to be hardest hit can be supported through the early months of the pandemic and beyond. There's a need to support greater use and adequate data for data modeling purposes. We're not going to have randomized clinical trials for many of the interventions that are candidates to be brought to bear in a pandemic situation. There's a need to use as sophisticated modeling techniques with transparency regarding the assumptions that are going into these models, with after their use evaluation as to how successful they were in predicting various outcomes or results. That requires an investment. When I was in the COVID response in the data surveillance group, we had modelers who bemoaned the fact that there were half a dozen throughout CDC. And one of the best things that CDC has done in the aftermath of COVID is launch a modeling unit. Now, I don't know where things are at with that, because we all know that's what's going on right now under the Trump administration and RFK Jr. is basically sledgehammering CDC into being a mock bureaucracy, to use Alvin Goldner, the sociologist term. That all began in Trump 1.0. You may recall in the way back that Trump, in his first administration, withdrew the CDC contingent in China. That was a real strategic and tactical blunder. And again, it goes back to how can we do a better job operating in conditions of uncertainty? We need to grab as much intelligence as we can in the early phases of outbreaks and particularly the outbreaks that have the potential for becoming pandemics. So there has to be an investment, and a long-term investment, in some of the infrastructure and the ingredients that are needed in order to develop the policies and that are best informed by what data we have and what tools we have to evaluate those data.
Great. So it is just after 5 o'clock, and so I want to open this up to to members of the audience. Pam, I presume, or Anna, that you are going to moderate this. Actually, I can look and see who's got their hands raised. There's other issues to be explored.
I have Jenny Mansbridge first, and then Jennifer McCoy, and we'll also monitor the chat for you, Rick.
Great, thanks.
So I would like to focus on the strong agreement between Francis and Daniel on the major problems in the attitudes and communications of public health authorities. I think you both agree 100% on that. Yet most of the focus of the papers is SSN distributed ahead of time, and most of the focus in Francis' response to Daniel has focused on the details of the empirical argument based on both the history and the differences between states. I think that's an extremely important empirical debate, and it deserves to be pursued. But what I'd like to, I hope it won't eclipse the agreement on what Daniel called the barrage of misleading or false information. That's the biggest fish to fry, in his words. How in the future can we reduce the official closing of the ranks around policies? And I understand completely the reasons for doing that. Namely, you're trying to convince the public of something. If you try to convince the public of something, you should be saying that thing, that thing, that thing, that thing, and that thing over and over again in more or less the same words with no deviance. But that's terrible epistemically, as both of you agree. So how do we handle that tension? And then second, how do we handle basically the finger shaking attitudes of many of my friends? You're so stupid, follow the science. I can't tell you how many of my friends despise those in red states who didn't do exactly what the blue states did. And those two, the unanimity of the public health officials and the finger shaking of my friends are two sides of the same coin. That's what I'd like to see us focus on in this discussion. How do we avoid those two things in the future?
Daniel, can I ask you to respond quickly, and then Francis?
It's a great series of questions, just very quickly, and reflecting my CDC experience. I served at CDC under 12 different CDC directors. Early on, in fact, the first one was a man by the name of William Fahey, Bill Fahey. And Bill's attitude was, if the press wants to know something, talk with them. And over time, what happened was a clamping down, where in order to talk with news media, you had to have communications clearance. That's another abuse of epistemic authority that occurred. That has to be totally revamped. There is a role for CDC experts, scientists, even if they disagree, to voice their opinions in social media. And to clarify that I'm speaking as an individual, but I'm speaking as an individual who works at CDC. I don't speak on behalf of the agency. I speak on behalf of my understanding of the evidence. I think too much of the misinformation and misleading statements that are produced and propagated through social media don't have enough of a counterbalance from folks who have spent a great deal of time, quote unquote, doing their own research. You know, we need to have an equilibration of some of these voices going forward.
Francis, do you have any thoughts about this?
I'll just say, I do think Jenny, as per usual, gets right to the heart of the matter, in that I think if we were going to learn from the pandemic experience, I think these are the lessons we need to draw from it. The debates about what worked and didn't work in the context of the pandemic are confined to that one issue. But this problem is much wider ranging. The question of how do public officials present scientific propositions, information to the public? What do they do under conditions of uncertainty? How can they influence policy while also lacking the kind of certainty that you would ideally want to have? Science rarely provides that. I think, what we saw during COVID was kind of an object lesson in what not to do. You had public officials going out repeatedly. It was almost a mantra during the pandemic, saying we know what works against COVID-19. And then, we learn in 2022 that it's an airborne virus and not only transmitted by droplets. They didn't know what worked against COVID. They recommended all these measures, 6-foot distancing and cloth masks that are very questionable effectiveness against an airborne a disease that's transmitted through airborne pathways. Other kinds of claims that were made on the basis of little evidence. Basically, I think it was policymaking on hope, on the basis of hope rather than evidence. We hope this will work. We don't have much evidence that it will. And then telling people that it would, and then as they discover that it doesn't, like, the vaccine would stop transmission. That was also overclaiming. It never did that. The effect is waning. So they shouldn't have made these assurances to people, and then they discover in their own lives that that information wasn't good. And so it's no wonder they lose trust as a consequence of that. So it's a very harmful experience for the credibility of scientific agencies in leading the public.
Thanks, and I think our next, Jenny McCoy, right? I do want to mention and highlight the fact that given that the book focuses on the relationship of science to liberal democracy, there's a couple things. In principle, liberal democracy is supposed to facilitate things like deliberation, facilitate learning, and especially in our federal system, states are the laboratories of democracy, but hopefully other kinds of public policy practices. The question to me is, in part, how does one accomplish those functions in a situation not only under what what public health folks describe as a frantic context, but also a situation of micromanaging and distortion. And this micromanaging, I should emphasize, and Daniel can attest, predates Trump. Former CDC officials really were under the gun, always felt themselves under the gun. So I think that gets us to the nature of the regime. And Jenny McCoy, speaking of regimes, is a perfect person to address this. So Jenny, you're up.
Thanks. And I can't wait to read the book, Francis. Thanks so much. And to Daniel, too. I was going to follow on that because I lived with 2 CDC officials during the pandemic, and we were every night, watching the news. One of them was a communications officials. And I know, from that person, the role of the administration of the White House in muzzling the communications from that time. And so, as Daniel said, they could not just speak as they would want. What I'm not clear, though, is what you both would conclude about the differences between, where, if there were differences within the CDC and between the CDC and the NIH in terms of determining policy, and where the politics came in, because we know that it became politicized very quickly and polarized, and became politicized by the president himself as an issue. And so, there's kind of those 3 levels that I'm wondering if you can respond to.
Daniel, I think this is in your court.
Yeah, I'll start.
I want to talk about your experience in Congress as well.
Okay, well, it's a really, really important area to talk about. Thank you, Jenny. And, there's no question that there is stiff competition within the various federal agencies, including within Department of Health and Human Services, without strict boundary lines. And whatever you think of Tony Fauci, he had a very successful presence through administration after administration after administration. And he clearly, and others, Deborah Birx, saw themselves as alternatives to CDC folks who traditionally would be, at the forefront of epidemic response in general. And that played itself out in ways that many of the thought and opinion leaders and leading scientists at CDC were marginalized. And that's an issue that goes way back. It's an issue that will continue. I'm very worried about CDC's future and what would replace CDC, if anything, in the event that we do have another pandemic. So the disaster that has been wrought already will have enormous and enduring consequences that absolutely need to be addressed. There are certainly also issues related to federalism and a lack of clarity between federal, state, and local roles. I will say that many of the state health officers and certainly the state epidemiologists have longstanding ties to CDC. And that's one of the reasons why I emphasize that 2017 pandemic plan, which came out from the Department of Health and Human Services, with CDC providing a lot of the intellectual throw weight behind it. The folks out in the states listen very carefully to CDC. I wish CDC sometimes listened as carefully to the folks in the states, but that's a long-standing working relationship. It grows out of CDC's own history as collaborating with states as far back as malaria control in World War II. So there are issues related to competition within the federal hierarchy and system, as well as between the various levels of government that are at federal and below.
Thanks. Francis, did you want to say anything about this, or do you want to move to other questions?
I would like to get the other questions involved, get other questioners involved. I'd like to hear from everybody to the extent that is possible within the time we have.
Other questions, please raise your hands.
Glenn Fear is next, and then Mike Evans, I believe.
Okay, go ahead.
Great. Yeah, thanks so much. This is an interesting conversation. I certainly agree on Francis's point that there's no the science, right? As much as that was the mantra, and appreciated Daniel's points about like the kind of unfortunate centering of biomedical expertise as the only relevant expertise in pandemic decision making. I think that's been an unfortunate, and I agree about all the challenges you've talked about with the nuances and in messaging and complex, in the face of uncertainty and complexity. I guess listening to the conversation, I have some trying to reflect on the ways in which I think we sometimes even lose conversation or lose nuance in this conversation. And so, and potentially oversell policy choices as policy choices at all. I think the language of lockdowns is incredibly inflammatory, and it's and somewhat misleading, right? So it's a messaging choice. It's a communications choice to call a lockdown a temporary, very short-lived stay-at-home order that was never enforced. And so I think it's complicated when we talk about, well, we have no evidence that this was effective. Well, we didn't really try it, I mean, I think that there was not a good faith effort. And part of, and then we don't really talk about the nuance. I think kids were the biggest losers in so many ways in all of this. And right, kids had often school closed well beyond what needed to continue to close because of outbreaks of COVID in schools, for years, and continues on now even. And we don't really talk about some of the ways we as a society made values-based choices about who to prioritize and who not to prioritize. We don't talk with nuance sometimes about the fact that it took, kids under 5 until summer of 2022 to even have access to an NPI or not a vaccine, and could only use NPIs, right? So I think I worry sometimes about rewriting history and kind of looking at the wake of what's happened and making choices about how to write the history. But I say all of this because I actually really think fundamentally what you all are getting at is this idea that we need to have better, more nuanced, more inclusive, values-based conversations. I'm a bioethicist, full disclosure, in policymaking and in pandemic and other kinds of healthcare decision-making. And I guess I wonder where you see as opportunities to approach policymaking differently, to do and foster those values-based conversations and have those really influencing decision-making in different ways than they currently do. And where can scholars be effective in pushing that?
I appreciate the question. I certainly agree with your overall take that we need to improve our ability to discuss values and we need to have the necessary nuance in our discussion of the policy choices that we make and that we face. On lockdowns, it's funny. You know, the terminology that was the shorthand that was used during the pandemic, and it didn't have the inflammatory tone that it has now. At that time, it's evolved over time. It's because I think Republicans and conservatives began to use it as, you know, the lockdowners. You know, they began to treat it as use it as a term of disdain. And so, it's taken on connotations that it didn't initially have. In the book, I use that kind of shorthand in talking today, not thinking that anyone would find it inflammatory, just given that it's a scholarly group. It's true. I would not use it if I was giving a public talk. I don't use the term lockdown. I always refer to stay-at-home orders because I know it has that resonance. But it would be interesting even to study like how and when that resonance developed, because it wasn't there at the very start. It's very interesting that you surface that. I also think, on your point about values, like to have a discussion about values, we have to also acknowledge that values differ across society, and that we don't all value the same thing or rank things in the same order. And that was always an obstacle to just following the science. The science can't tell us what to value. And so we skipped over that part too. In addition to, skipping over acknowledging the uncertainties around these measures, like what works and what doesn't. It's not known. What you can do as an individual to protect yourself from a respiratory disease may not scale to society, to the whole, at a society level. We don't know that, because we're so interdependent as a society. A third of people were essential workers. They had to work all the time in person all through the pandemic. So what might work for an individual, especially an individual who's able to work from home and still receive an income, may not work at a societal level. So there's many questions around what works, and I think this goes back to Rick's question, which I failed to answer at the beginning, which is what do we do in the presence of all this uncertainty? And I think there's just no substitute for policymakers being honest with people about what they know and what they don't know, even at the cost of people drawing their own conclusions. I think that's much better than pretending like you know when you don't.
Thank you, Francis. Daniel?
I agree with what Francis has just described. I'd add that I think if policymaking is approached as a series of tasks where there can be failure points in the tasks that are undertaken, we need to look at how we can do those tasks differently and in ways that bring the thoughts and inputs from ethicists or someone put in the chat, rhetoricians, and incorporate them in the tasks. At CDC, the program that I entered, the Epidemic Intelligence Service, over time, there have been non-MDs increasingly who've been brought in. I think it's important to have other voices as well from such fields as bioethics, sociology, political science, who go through that training and are part of the tasks the CDC undertakes, such as evidence reviews and consultation with states regarding policymaking.
I think Mike is next, right?
Yeah, I was just gonna suggest, maybe we should think of this a little bit on two different time frames. I mean, there's on the one hand, there is all the difficulties in the moment that everyone's acknowledged. Even given that they performed suboptimally. I think there's Francis, you guys have a whole chapter on noble lying that took place. There's a temptation, even when they to actually knowingly say false things that and I think or at least and certainly a temptation to claim greater certainty than they're warranted in claiming, and knowingly they know that they have that they're less certain than they're claiming to be. And I think part of this is that there's a tension, I think, between leadership and collective action on the one hand and what science demands on the other. Leadership and collective action are about require building a certain amount of certainty and and belief in the population. It's kind of like what Jane Mansbridge said before she had to jump off, but about how, there's this felt need to get the public to comply with what they've decided, whatever they've decided on. Let's try to get compliance, right? Let's try to sell people on this. And it seems to me that some of that's inevitable. I mean, it clearly got abused. It clearly went too far. It clearly had a devastating impact on their credibility by doing it in the way that they did. But some of it, I think, is inevitable. And maybe I'm wrong about that, but it seems that so one question. So one thing I've been wondering about, is there some way to protect the science? Is there some way to have a division of labor or a separation of powers? Where the politicians and the public leaders, where they have to stick their neck out and take the heat. They don't want to, Francis, you know this better than anyone. This is credit claiming and blame shifting. I mean, they would love to, they want to blame the Supreme Court. They want to blame everyone but themselves, for taking these tough, uncontroversial positions. So there's a strong temptation to shift the blame, to let the scientists take the heat. But what we really need is for the scientists to not take the heat, and for the scientists to be as honest as they can be. Maybe not be the center, be the focal point publicly, but at least behind closed doors, be as honest as they can be. And we need,
This is a great
okay,
question.
so that's what question.
I want to hold you there, Mike, because we only have 5 minutes left. So let's raise that question of division of labor.
Let me finish the thought real quick. Just that, and then but on the time frame thing, also, though, it seems that the most important thing, and this is maybe what I prefer you address, is afterwards. Though we have lots of time to deliberate. Now we have time to be critical, and I think those damning claim you make in the book, Francis, is that your book is one of the first efforts to actually all these years later is one of the first real efforts to do this. We still haven't had a real major congressional hearing to try to and do you see that improving? Do you see that situation improving? Because there's no excuse. Now is when we should shine. A liberal democracy, according to Popper, should learn from mistakes. This is what should be great about a liberal democracy, right? And are we not, do we see an improvement in this, or is it just us right now? Is this it? These little discussions and people reading your book and talking about it. Do we see an actual, because so anyway, none of those excuses apply. What I'm saying is when we're now trying to learn the lessons afterwards. Okay, sorry, Rick.
It's okay. Okay, so Francis and then Daniel, and then we're coming across on our drop dead time. But Francis, go ahead.
I'll be short, and I'll confine myself to the last point that Mike made, which is that now we do have time to take a look back and to learn. And I am very struck by the reluctance, not just of government agencies. So Daniel mentioned the failure to to release information. Now, of course, I'm sure there's political leaders involved there, but it's not just government. It's that it should be happening in society. Like, why are there so few conferences about this looking back? This is a subject for policy schools. It's a subject for public health schools. Many different disciplines have something to say here. And there has really been a turning away. I will say in our defense as a society that's a pattern with pandemics, and that we saw the same thing happen after the 1918 pandemic. It's one of the things that comes out in the Barry book, that there was a reluctance to look back. But what his number one lesson that he drew from looking back at the 1918 pandemic is that leaders have to be honest with the people. And so we can try to learn it again here after this pandemic experience.
Daniel, last word.
Yeah, I agree. I think, unfortunately, I think time is slipping away. People move on, people disappear from scenes. Piecing together the history accurately becomes harder and harder. Records disappear. I'm worried that we're past peak time for actually doing the deep dives and understanding better where at the task level things went awry.
Well, hopefully SSN can contribute to that process of assessment. I want to emphasize a couple of things that I drew from this discussion. One is that dealing with this has to take account, explicit account of the context. We're talking about federalism, we're talking about Trump, we're talking about polarization beyond Trump. Daniel's point about the lack of data, I think really data as a dependent variable really needs to be emphasized. And then the question of variation makes this even more difficult, that what works in one place is what's appropriate for another place. Merits study by social scientists especially. So we are at 5:30. Pam, did you want to have any closing statements or anything apart from many, many thanks to our participants?
Yes, thank you to our speakers, certainly. And I think Bernie Thomas would like to say a bit about the next in this series.
Yes,
What's coming
thank
up?
you, Pam. Yes, just thanks very much, Francis and Daniel, for coming and doing this great talk and great discussion. And thanks, Rick. And our next panel, next Zoom, will be probably in around February. We're going to do 2 in the spring. The next one will be about the role of third parties in securing democracy and challenging the shift towards authoritarianism. And this is a role that third parties used to play, and critical role in American politics that has disappeared. And so it's now very important to come back and have the discussion about why they're so weak now compared to what they were 100 years ago, and what strategies can be developed to get them back into a point of actually pushing our system maybe into a better direction. But thank you again for everyone.
Thanks,
for
Bernie.
the great discussion. Thank you for the participants. It was wonderful.
Thank you, everybody, very much. And shout out to my former classmate, Pat Bowling. It's great to see you.
Thank you, everyone, for joining. We very much appreciated this discussion. We'll have a video up on our site pretty soon. We'll share that. If you haven't had a chance to watch Jennifer McCoy's video from the first session, we'll also make that available again in a link to all of you, so you can check that out. But I think, again, thank you all for coming. Thank our speakers, Francis Lee, Daniel Pollock, Rick Donor, for moderating. This was really a wonderful and thought-provoking discussion. Thank you.